Hypotension with bradycardia is an unusual set of vital signs, and it has a relatively limited differential diagnosis that we have to be thinking about. That list includes things like hyperkalemia, beta blocker and calcium channel blocker toxicity, clonidine or digoxin toxicity. You can see this with neurogenic shock, blood in the belly, hyperkalemia, as well as advanced AV blocks. A lot of those things we're going to get from our history. If the patient has trauma with hypotension and bradycardia, I'm thinking about neurogenic shock. If the patient is a young woman coming in with abdominal pain, then I'm thinking about ectopic pregnancy. All that blood in the belly is giving vagal stimulation, causing bradycardia and hypotension. Beta blocker and calcium channel blocker toxicity can be a little bit more difficult for us to pick up because sometimes we're looking for overdose. But we can see hypotension and bradycardia due to beta blocker or calcium channel blockers without overdose. This is particularly common in those patients who have a renal hit, they accumulate their beta blocker and calcium channel blocker, and that leads to toxicity. We can see the same thing with hyperkalemia. They get a renal hit, that potassium accumulates. While it is a relatively short differential diagnosis, we do have to think about all of these in order to initiate the appropriate treatment. I'd love to hear from all of you. If you have other diagnoses that you've seen causing hypotension and bradycardia, drop those in the comments so we can share them with everybody.